Good morning, good afternoon, and good evening, everybody around the world, and welcome to today's webinar hosted by the Aviv Clinics. I'm Dr. Mohammed Elamir, and I have the distinct honor to introduce our speaker today, Dr. Shai Efrati. I'm speaking to you today from our main headquarters in the United States in Central Florida. I'm here in the Aviv Clinics, which is the world leader in brain and body performance. Here we treat a lot of things related to the brain and the body: the aging process, cognitive decline, stroke, traumatic brain injury, fibromyalgia, and yes, even long COVID. And today we're going to learn about the latest research about treating long COVID with Dr. Shai Efrati. Dr. Shai Efrati is an amazing person that I've gotten to know over the last 3 years. He is a physician. He is the head of the Neuroscience Center in the Segal Center in Tel Aviv University in Tel Aviv, Israel. And he is also the chair of our medical advisory board here at the Aviv Clinics. Today, we're going to learn many things about his latest research and what that treatment can do for you and anybody you love. COVID has touched everybody around the world. And whether you've had COVID in the past, had it recently, or have a loved one that's been affected by COVID and haven't been quite right since then, or if you just want to learn about better ways to heal the brain and body, you came to the right place. So without further ado, I'd like to introduce Dr. Shai Efrati.
Hi, Mo. It's always good to see your face. What we're going to do in this webinar, I'm going to share with you the journey, the COVID journey, I call it, that we started something like 2.5 years ago, when at that time, nobody really know what COVID is. Needless to say that nobody knew anything about post-COVID. And actually, when the epidemic started, I was in Florida in what is being established today as the Aviv Clinic. At that time, the clinic wasn't ready yet. And I came to Florida especially to see the implantation of the chamber. And at those times when I was in Florida, we heard the news from Israel that we have some bizarre cases of patients who had severe pulmonary infections that are going into the ICU. And then for the first time ever, we heard about shutdown of Israel, meaning people have to be on lockdown at their houses, and the airports were closing. And when I heard that, I said, oh shit, I'm not going back to Israel. I'm going to stay here until all of this craziness will pass. And it didn't pass in the first week, it didn't pass in the second week, and it happens to be that I stayed in Florida for 1 month. And after 1 month, I gave up and say, okay, now I need to go back to Israel because nothing is changing. And at those days, everybody was afraid from the acute infection. Nobody thought about any long-term consequences. And I cannot forget the time going to Israel through New York, being at the airport in New York. I think it was me and 5 people more who were in the airport. It was an amazing experience. And when I came to Israel, I need to be in isolation for 2 weeks, which is something that everybody takes today for granted, but for me, it was a big issue. I came back to the hospital, and as the head of the R&D in our medical facility, and as a professor at Tel Aviv University, who have the privilege to have some of the leader scientists under my supervision, we were thinking together what should be our contribution. And again, at those times, nobody thought about the long term. And we said that our contribution will be to do a research to understand the immunological reaction, which antibodies are going up, when they are going up, what are the kits, the different antigen kits that can work with that, how can we make that better? And today, actually, the kits that you have, everybody has at his home, these are the kits that we evaluated at that time, the sensitivity, the specificity of that. So that was the first focus on our research. So we were able to map the immunological response in patients with severe and mild and moderate COVID, And with this regard, we wanted to follow up and see for how long the immune defense that we developed during the acute infection will protect from a second exposure or a second disease. And for that, we follow up the patient. And I remember that something like 2 years ago, we said, oh, there's something quite weird going on. We have young patient who didn't have any severe consequences of the disease at the acute infection. And we noticed that those people, I don't want to call them patient because they were supposed to be totally healthy, suddenly complain of continuous cognitive decline, complain on loss of attention, loss of memory, emotional stress, anxiety. And we were looking at that and saying, what's going on? And when I discussed this with my colleague from the university, they told me, Shai, this is bad time. It's a stressful time. And it's probably all emotional. And it will pass because people cannot go to work and go to the university to study, etc., etc. But at those times, we made a bet. We said, this is too weird. This is too weird. We need to dig into that. There's something weird going on. It's impossible that people young people, months after the acute infection still complain on that symptoms. And that's where we initiated the long COVID research program that we have. And 2 years, taking fast forward 2 years where we are now, I will try to summarize for you what is our current knowledge on what is known today as long COVID. Today we actually have a definition of the WHO of what post-COVID is. Luckily, the definition that we use, the criteria that we used 2 years ago, is actually the same criteria that is being used today by the WHO. And that means that people who have persistent symptoms more than 3 months after the acute infection, and these symptoms are continuous symptoms. It's not that you have relapsing symptoms, and it can be related to cognitive, to emotional, to physical symptoms. And we don't have other explanation that can explain those symptoms. We call it today long COVID condition. And if we want to look at the natural history, we actually have 3 phases. We have the acute phase, the acute COVID, which is usually up to 4 weeks after the acute infection. We have what we call the subacute or persistent symptom of COVID, which is up to 12 weeks. And during that period of time, we can still find some virus, remnant of the virus in the different organs in our body, and we will touch on that. And then we have what we call post-COVID symptom or long COVID condition, which is symptoms that persist beyond 12 weeks. And that's going to be the focus of our webinar today. With respect to that, when we are speaking about post-COVID, we have different clinical presentation that can be related to that. We have cognitive symptoms, we have psychological symptoms or mental related symptoms. We have cardiac symptoms, we have physical symptoms, and we have the long related symptoms. With respect to the physical symptoms, the most common symptom is fatigue. We see fatigue in more than 90% of the people who have long COVID. The fatigue is not necessarily related to muscle or to power or the respiratory symptom. The fatigue can be related also to mental fatigue. People need to sleep during the day, waking up tired in the morning, okay? Reading a book, being tired after reading 1 page, etc., etc. So this is the fatigue. The people who have lung infection with remnant of lung infection can be suffering from shortness of breath that is related to the damage to the lungs. There are some people who have dyspnea not because of damage to the lungs, because their cardiac function, the synchronization of the cardiac function is damaged, and we will give you some highlight on that in a study, in analysis we have just finished. There can be pain. People are suffering from pain all over their body. We see hair loss as a common symptoms, and things like that. With regard to the cognitive and the psychological symptoms, we are speaking about memory decline, attention, concentration difficulty, people describing brain fog. Okay, everything is foggy. The way they express the world outside is under fog. We see some symptoms that at the beginning, when we started it, we didn't understand the magnitude of it. The symptoms are mental symptoms, anxiety, depression, sleep disturbance, headaches. All of these are the cognitive related symptoms. When we're speaking about the magnitude of the long COVID, there is a difference between pediatric population, children, and adult. In adult, we are speaking about 20 to 50% of the population, taking into consideration that that includes all the time period that we had before we had the effective immunization or vaccination that we have today. And even in pediatric population, we see that something like 10 to 20% of the pediatric who have COVID may suffer from the long-term consequence of that. And this is a very important issue that we usually tend to ignore. There are risk factors that increase the tendency to develop long COVID. We're thinking that the Delta is more virulent with respect to the long COVID than the Omicron. It may be related to the variant, but it can also be related to the number of people who are vaccinated where they're exposed to the Omicron. We know that women are more exposed to developing long COVID. Age always play a part, but the important thing is that the chance to develop long COVID is not related to the severity of the acute infection. You may have mild, moderate, or severe acute infection, but still you have the same chance to develop the long-term consequences of the post-COVID symptom. So what's going on? What we are dealing with? Okay, and the first focus will be on the brain, because this is the most common symptoms, and actually the brain is who we are. Okay, what we have between our ears, this is how we express what we feel, and this is also the way we see the world. We understand what's going on around us. So what's going on in the brain? We know that the virus, the COVID, can penetrate the brain through two major pathways. One is here, above the nose, the bone that we have, the scalp that we have over here. We have a penetrated bone that enables us to smell and sense the outside environment. We call it the cribriform plate. So the virus can penetrate through here. While it penetrating through here, is reaching the frontal lobe, the lobe that we have here in front of our face. Okay, it can penetrate the frontal lobe. It can bind to the neurons. Once it's binding to the neurons, it can inject the genetic material into the neurons and cause damage to the neuron function. This is one thing. The second thing, in the brain, in addition to the neurons, we have what we call glial cell. The glial cell are the supporting cells that are aiming to preserve the homeostasis, the environmental that is supposed to enable good function of the neurons. The glial cells have receptor, we call them ACE2 receptor, that the virus can bind to. And once the virus is binding to that, it is causing gliosis, inflammation of the glial cell. So this is what happens when the virus is penetrating here, above our nose, through the cribriform plate. Another penetration route, it's through the bloodstream. For the unfortunate in whom the virus penetrates the circulation, the blood vessels. It can go through the blood vessels into the blood vessels that we have in the brain, bind to the receptor that we have on the endothelial cells, activate the coagulation cascade, meaning it can cause thrombus, occlusion of small blood vessels, just like tiny strokes. And because of that, we are losing the functionality of the tissue. This is also the reason why we are giving today to patients who are being admitted to the hospital, we give them anticoagulant in order to reduce the chance for occlusion of the blood vessels. Today, 2 years after, we can see how the virus is penetrating the brain. In the picture that you have in front of you, you can see the cribriform plate we spoke about. In red, we can see the virus, and you can see how the virus is going through the cilia into the brain tissue. In this slide, you can see in yellow, you can actually see the virus binding to the neurons and injecting the genetic material into the neurons. This is the damage. This is how it happens. And we get this amazing microscopic picture for people who were unfortunately dying, and we did an autopsy in order to see exactly what happened in the brain when they have the COVID. The last thing, the third pathogenic pathway, is occlusion of blood vessels, and this is how the virus is binding to the boundaries of the blood vessels, the endothelial cell, activate the cascade of thrombus, and then we can see things that we usually see at an older age, in aging population. We see occlusion of small blood vessels, we see strokes, and this is where the arrows are. You can see the stroke generated in the brain, and unfortunately, we see a lot of young people with an old brain, okay? Just like an old guy with the occlusion of the vessel. So once we realized that, we said, okay, so we are dealing with the damaged tissue. So how can we repair the damaged non-functional tissue that we have in the brain? Fortunately, something like 2 years ago, we initiated a whole different research program that was aiming exactly to that, aiming to regenerate damaged brain tissue. And summarizing 20 years of research, we can look at this picture that you can see a wound, a peripheral wound, and you can see a wound in the brain. To make a long story short, actually today we understand that the basic of the wounds that we have in the brain is very similar to the basic on the wounds that we have in the periphery. And no matter what wound we are dealing with, the crucial element needed for repairment are more or less the same. The main difference is that the wound that we have in the brain or in the periphery, the wound that we have in the periphery, for example, we have a wound in the brain, in the leg, the wound in the brain, in the leg, it's something that is tangible. We can see it. We understand what we are dealing with. However, the wound that we have in the brain, it's, it's high-tech. We are doing CT, MRI, we are speaking at the brain in a mystic fashion, but it's a tissue, it's a wound. And no matter where the wound is, there are 4 crucial elements that needed in order to repair it, to the recovery of the wound. And these elements includes energy, because nothing happens without energy, and energy at the cellular level is actually oxygen. We need a trigger, because nothing starts without a trigger. We will not build a house without a trigger, and we will not go out of bed in the morning if we don't have a trigger. And we won't start the repair cascade if we don't have a trigger. We need stem cells, cells that can differentiate into the different tissue. And we need generation of new blood vessels, because we just said that the blood vessels are damaged. So let's go in short one by one and understand the relative of it to the brain. When we are speaking about the brain is up here. And at each time point, the brain is utilizing all the oxygen that is being delivered. The oxygen is being delivered from the carotid artery that we have in our neck, and the brain utilizes all the oxygen. But even though the carotid are good, the blood vessels are good, the amount of oxygen that is being delivered is sufficient only for something like 5 to 10% of the maximal capacity of the brain. And what the brain is doing differentiation, is taking oxygen from one area to the other, meaning if I will move the hand, it will go to the hand. If I'm moving the leg, it will go to the leg. So it means that at each time point, the brain is utilizing all the energy needed. You can imagine what happens if we have a wound or if we have occlusion of blood vessels. By definition, any wound that we have in the brain is oxygen deprived. So if we want to change that, and if we want to give more oxygen, we need to compress more oxygen per square. So more oxygen can go through our lungs, through the lungs to the circulation and to the brain. And for that, we are using those switches that you see in front of you. This is actually hyperbaric oxygen therapy. And when we are referring to hyperbaric oxygen therapy, we are referring to that, not for a tube, not for a sack full of air. This is how it looks. And when we are taking the people inside, we are compressing the chamber to 2 attas. The patients are sitting inside, they have the mask on. And by doing that at 2 attas with 100% oxygen, we are increasing the blood oxygenation from 100 mercuries to 1500. This significant incline makes the dissolved oxygen in the blood sufficient for all the energy demand, meaning oxygen can be delivered even to location when the red blood cell cannot go. So this is the first element. This is the oxygen, and that's how we generate it. The second thing is a trigger. As we said, no repair will happen without a trigger. So what is the most powerful trigger for the repair mechanism? The most powerful signal that we have in our body for initiating the repair mechanism is hypoxia, is lack of oxygen. Meaning, once the body sends hypoxia, lack of oxygen, is saying, oh my God, there is a damage. I need to activate all the repair mechanism in order to overcome this damage that's probably happening. The only problem with hypoxia, it's unhealthy, meaning if I will take a person, hold his breath, stop his heartbeat, he will have hypoxia, lack of oxygen, and then I have the trigger, but he will have real injury. And this is where we are coming into the game again. He said, what is happening? Does the body sense absolute value, or does the body sense the delta, the fluctuation? It happens to be there is no absolute in nothing. I will feel that I'm rich or poor, not based on the absolute value that I have, based on what my neighbor have. And even at the cellular level, the cells that will feel they are oxygen deprived or having extra oxygen based on what they have a couple of minutes ago. So what we are doing, we have a trick. We are putting the people in the chamber, increasing the oxygen level to very high, and then all we have to do is ask them to take the mask off. When they are taking the mask off, then the oxygen is declining from very high back to the normal. And this decline from very high back to the normal is being sensed by the body as hypoxia, as lack of oxygen, even though there is extra oxygen. This is what we call the hyperoxic-hypoxic paradox. And that's trigger at the cellular level, the HIF, the hypoxic-induced factor, which is the factor that once it's activated, it's initiating the expression of a full cascade of genes that are aiming to repair whatever is need to be repaired. By the way, there is a Nobel Prize over it that was gained a year ago. We can see at the brain in different models that when we are doing our hyperoxic hypoxic paradox, it's not that the chamber, it's the fluctuation that we generate. We are initiating the HIF expression even at the brain tissue. And by that, we are triggering the cascade of events needed for the repair. So we have the energy, we have the trigger, but we need a building stone in order to repair. And those building stones that we have in our body, the repairs that we have in our body, we call them stem cells. The stem cells are unique cells that are dormant. They are dormant with very low metabolism, so they can survive the insult that causes damage to the rest of the tissue. But once you are triggered them, they start to replicate. They start to replicate, and they can differentiate into the missing tissue. It happens to be that in the brain, we have also stem cells. We call them neuronal stem cells. We can find a high concentration of them in the hippocampus, and it's easy to trigger them. Not easy for us, because what we are doing, we are generating the fluctuation. And once we are generating the fluctuation, the HIF is up, then the stem cells are waking up. They're saying, oh, there is a damage. Let's start to replicate. Let's start to differentiate. So by doing that, we can induce stem cells. And this is the results of one of our studies when we are taking people into repeated hyperbaric chamber, which is actually the hyperoxic hypoxic paradox protocol. It's not just hyperbaric treatment. We need to find another name. And you can see that after every session, the amount of stem cells is going up. And something like after 30 sessions, we have huge amount of stem cells that are flying all over, looking for places to settle down. And then we need to keep them up for additional 2 months, so they can make the repair needed. So these are the stem cells. But stem cells is nice, but it's not enough. If I will take this plant and put it on what you see on the left side in this desert, what will happen? Probably not much. The plant will die. But if I will take this same plant and put it on the right side, it will flourish and grow. Why? Because we need a good ground in order to make it flourish. Speaking about COVID, we spoke about the occlusion of the small blood vessels that we have. So on the left, you can see a potent vessels. You can see the perfusion is very good, the oxygenation is very good. However, in post-COVID condition, we have those occlusion of the blood vessels. So whatever happened after those occlusion, it's actually a desert. And no matter what plant we will put in that desert, it cannot grow. So in order to change that, this is again the hyperoxic hypoxic paradox. That's what happened when we are in the suite with the high oxygen level. The oxygen is going by diffusion, and this is not a desert anymore. Now we have the flourish land. We can take the stem cell, put them in, they will grow, they flourish. And then once that is happening, then we can see also generation of new blood vessels. We have the trigger, we have the energy, and we have the stem cells that can differentiate into the blood vessels, and then we can see angiogenesis. Once we have this, we have a new steady state, and the wound was recovered, and that's it. And here we can stop the treatment, and the patient will do good from this point on. We haven't started, of course, 20 years ago with post-COVID. We started with classical brain injury, for example, stroke patient, okay? The first study we have done on a stroke patient, we took patient after stroke, more than 6 months after the stroke. And we developed a unique brain imaging that enable us to see which tissue is totally dead, which tissue is damaged but not totally dead. And the not totally dead tissue, this is where we can help. So the blue that you see over here on the left side is a totally dead tissue. You can see that the blue does not recover, it's stay necrotic. However, the surrounding tissue that we mark in green, this is the tissue that can be repaired. This is the tissue where we will bring the stem cells, the oxygenation and generation of new blood vessels. This is the tissue that will regain the function. Today, we made additional progress. We are using MRI. So if you look at the classical MRI, like you see in front of you of post-stroke, you see a necrotic tissue in black. This tissue we cannot help. And when we are adding the perfusion, you can see the blue and the green area over here, that this is our target tissue, that once we are treating it, we can repair the tissue with what we just said, the hyperoxic-hypoxic paradox. And we can use that phrase from this point on, because this is not just a hyperbaric chamber. Now you are more educated than that. So the question that we had when we started the second study was, can we regenerate the damaged brain tissue and improve the performance of post-COVID patient with the hyperoxic-hypoxic paradox? That was our question. And what we did in that study, we said, at first we will focus about cognition. Why? Because the brain is the most important organ in our body. So we took patients who are complaining on cognitive decline. That was the inclusion criteria. In addition to the cognitive decline, they can complain on shortness of breath, they can complain on hair loss, they can compare of problem in smelling, tasting, and all the different symptoms that we are all familiar with, but they had to have a cognitive decline compared. And then we did all the brain imaging analysis, we high-resolution MRI, perfusion, functional, and DTI MRI that we can see the nerve fibers themselves. And we randomized them into two groups. One group received the treatment, the hyperoxic-hypoxic paradox protocol treatment, and the other group received placebo, meaning they were going into the chamber, we were making noise, increasing the pressure a bit, but they didn't get oxygen by the mask. They were thinking they are receiving the treatment, but unfortunately they did not. And then we reevaluate them after 2 months of either treatment or a placebo treatment, what we call sham treatment. The complaint, everybody had to have a cognitive decline complaint, but in addition to that, many of them have physical, psychological, smell, taste problem, they had it all. We evaluate whether our placebo was well taken, and it happens to be that indeed the perspective of the patient, whether they are receiving the treatment, yes or not, was more or less the same in the two groups, meaning we were able, I don't want to say it, it doesn't sound good, but I will say it, we fooled them, okay? We fooled them in a good way, meaning they didn't know if they received the treatment, yes or not. The physician didn't know, whoever is doing the test analysis didn't know. And we evaluate everything. We evaluated the brain by the MRI, the DTI, we evaluated their functionality, we evaluated their motor, psychiatric symptom, anxiety, sleep disturbance. We also evaluate the heart and other function that we will let you see. To make a long story short, and I will try not to mix you up too much because the professional can read the article, what we see as the results of this study, we see that the functions, the cognitive function that are related to the frontal lobe, where the virus is penetrating, these are the functions that are improving with the treatment. And this function includes executive function, meaning our ability to do multitasking or complex cognitive tasking, attention, our ability to concentrate, information processing speed, and memory. I'm referring to the short memory, what we call memory. These cognitive domains improve in the treatment group, but unfortunately didn't improve in the placebo group in a significant manner. Meaning the people in the placebo group are getting used to their limitation. They are getting used to live with those limitations, meaning they will read less, they will learn less, they will write everything because they cannot memorize it. But their function is not really improving. Of course, that at the end of the study, we took also the placebo group to get the treatment and improve them, because this is the ethical things to do. So if we are looking at it, we can see that in addition to the cognitive domain, we see that the fatigue was significantly improving. People were less fatigued, they gained back their function again. We can see that the sleep, which is something that we didn't realize how significant it is when we initiated the study, the sleep disturbance are improving. We saw that psychological symptoms are not really related to the lockdown, are not really related to the environmental stress. They are actually related to here, to the tissue that we have over here, to what we have between our ears. Once you cause in a tissue in a damage in a specific location, then you may have PTSD-like symptoms, then you may have depression, then you may have an anxiety. We are the tissue at the end. That's surprise, surprise. And we can see that many patients who were suffering from systemic pain, the problem why they are feeling the pain is not because they have a problem in specific location. The problem is in the part of the brain, for example, the insula, who is responsible for interpreting the signals that are coming from our body. Once these areas in the brain are damaged, then the signals that are coming from the body are malinterpreted. And that's why they sense pain. They are sensing the alarm, but it's a false alarm because there is no real damage in the location where they're feeling the pain. But this false alarm is terrible. It's terrible. They're living with false alarm all the time. The amazing thing and the good thing, in every bad thing, we have good things. So the corona in general is a bad thing, but I always enjoy seeing the good in every bad. Because of the corona, and because we have relatively young, healthy population that suddenly develop different kind of cognitive and psychological symptoms, we can learn a lot about the brain. And we can see correlation between certain brain area to the symptoms that the people develop. And this correlation teaches us a lot about the physiology of the brain. So it's very enjoyable for people who are dealing with brain science or brain research. Of course, it will be better without it, but once we have it, it's amazing to learn more about the brain. And for that, we had done also functional MRI imaging, meaning while the people are inside, we can see the exact connectivity between the different area of the brain. And this is another study we have finished that hopefully will be published soon. We can actually see the network in the brain, how the different parts of the brain are connected. If we have a damage, what will happen in the clinical presentation, and once we are curing that damage, what will happen as a result of that. This is huge for us because we can understand the brain better. I spoke a lot about the brain, but we have just finished 2 weeks ago the analysis of the part related to the heart. We have many athletes who complain that after the COVID, they are not in the same fitness that they used to have before. Meaning running 5 miles, it's much harder for them. They don't have problem while walking. And when you are doing the scan of the lungs, you don't see any problem in the lungs. And when you are doing a normal echocardiograph, ultrasound of the heart, you don't see any heart function. But in a study that we have done, we have did a very high resolution echocardiograph of the heart. And we are looking about the synergism of the contractile of the heart. And then we see that something like 50% of the patients in this study have problem in the synchronization of the contractility of the heart. And once this is happening, then you are not fit in the same way you used to be before you had the COVID. Your ability to run, to climb the stairs and things like that are significantly less than what before. And surprisingly, when we are doing the hyperoxic hypoxic paradox, increasing the stem cell generation of new blood vessels and improving the tissue repairment, it doesn't happen only in the brain. We can see that it's happened also in the heart, and people can regain their physical function again. If I want to conclude, I can speak all day about the different aspects, but that's enough. People are marking me that I need to finish and give time for questions. The conclusion is that long COVID is being caused by a real biological damage. And the symptoms that we have, it's not a fiction, okay? It's not something that we just imagine. It's something real. These are wounds that are caused by this virus. In order to diagnose it, we need to use a higher resolution imaging of either the brain or the heart or the physical function. And once we see the wounds and characterize them, many of those wounds can be repaired and people can gain their functionality again and gain back to their normal life. This is not a magic. This is initiation of repair mechanism. This is repairments of wounds. It takes time. And whoever suffer from this unpleasant, to say the least, symptoms, it's not your imagination. Unfortunately, it's not improving, at least with our study, a long time. Don't get used to it. Don't take your limitation for granted. Go to professional, do the evaluation, see what the problem is, and if there is the type of wound that we can help, repair it and regain your life. The long COVID is probably the real problem that we are facing today at those times when we have a good treatment for the acute infection. So I will make a pause over here and give you time to ask questions. But before that, the last thing that I want to mention is that when we are speaking about hyperbaric oxygen therapy in our study, the real thing is what you see on the left side. This is how the treatment is being given. It's not the tube or the sacks that are full of air that we see on the right side that many people are buying by Amazon or whatever it is and put them on the backyard. This is not it. Don't get into that. This is not working. It can be dangerous. This is actually less than our placebo group. If you need the treatment, your health is important. Go to professional who knows what they are doing. You can see a multiplace, an example on the left side. Do evaluation, a good evaluation before. Mark the problem, mark the wound, and treat accordingly. And I will make a pause over here. Thank you very much for being patient with me, not real patience, but now we will leave some time for question and answers.
Thank you, Dr. Efrati. This was a great webinar and lecture. We all, who are in the space of medicine and treating COVID patients, I think the biggest thing is we know we have a new tool now to address the changes in the brain and body because of COVID. We've been monitoring all your questions. So if you have a question, it's not too late. Please type in your questions in the chat below. But I'll kick off with the first question, and that is, where is this treatment available? Now that we have the data and the research to prove this is an effective treatment, where can somebody get this done? Well, I'm talking to you from one of those locations. I'm here in Central Florida, just an hour north of Orlando. Dr. Efrati speaking to you from one of our locations in Tel Aviv, Israel. And we have a third location currently in Dubai, downtown Dubai. So if you're interested in speaking with me or one of our physicians, we'll put some information about how you can contact us and how to get a free consultation. Our next question comes from Marjorie P. Can all hyperbaric oxygen chambers treat long COVID even at a lower pressure? And Dr. Efrati, I know you started talking about the differences, but if you want to expound on that.
So what we call soft chamber, mono chamber, low pressure, this is our placebo group. So it doesn't have the effect. More than that, all of those soft chamber or low chamber have very bad quality assurance. So it doesn't matter that they are not effective. It's important that they are unsafe and you don't know what is the quality of the air that is going inside. So to make a long story short, as I said before, your health is important. There's a lot of fogs going around. Don't go there, okay? Go to professional. How do you know that the place is well suitable? First of all, you need a professional physician that will evaluate you and say whether you're suitable, yes or not. You can look at the chamber, see that it's a multi-chamber, that you can go inside with mask on, mask off. You can see our protocol and see whether this location is indeed given the appropriate protocol, and see if this location can do the appropriate evaluation of the brain with the high resolution imaging needed. Once you have these domains in place, then it means that you are in a good hands, so you can move forward and get the treatment at that location.
Excellent. Well, thank you for that. Our next question comes from Eric M. If you can treat cognitive decline or cognitive changes due to long COVID, what other diseases can you treat related to the brain?
So again, this is an excellent question, because with what we are doing, the hyperoxic hypoxic paradox, what we are using is we are treating wounds. And from our perspective, it's less important what's the primary cause of the wound is. What's important is characterize the wound. And if it's the kind of wound that we can help, then that's great. So the studies we have done in the last 20 years, we're focusing, I show you some data on stroke patient. There is people who are suffering from traumatic brain injuries, meaning mechanical injury to the brain. There can be different type also of infection, hypoxia. So the answer is yes, we can treat it if we can characterize the appropriate wound and see that the type of tissue that can be repaired is indeed there. Then we have the green light to move forward to the treatment.
Excellent. Our next question comes from Brandon R. How long do these results last?
It's a wound. So once the wound was fully repaired, just like any other wound, so the tissue is repaired, it will last, unless we will have additional insult. So based on the data that we have today, and we have a follow-up of at least 1 year, so the perspective that it's a wound that was repaired, hold the people who got the treatment, recovered, and they doesn't have any symptoms left.
Excellent. And I think that's feedback I always get. When you think of the brain as a wound and you address it as a wound, then it's easier to understand how you can treat it. Our next question comes from Ruth B. How do I know if this treatment will help my specific long COVID symptoms?
The answer is very simple. You need to go to professional. First of all, make an evaluation to see that what you have is indeed long COVID, okay? Once you have the answer that it's long COVID, then the next step is evaluate the brain, see the damage. And if there is the type of metabolic injury that we can see with the perfusion MRI, functional MRI, NDTI, then you can know that the treatment can help you. If we don't see that, then this kind of treatment is not suitable for you.
Excellent. And later on, we'll talk about how to contact us for that free consultation with me or one of the physicians, and we can go over your specific long COVID symptoms and tell you if our assessment can help diagnose it. Our next question comes from Dave O. Would I have to do the treatments every day, or can I do a couple of treatments in a few weeks and then take a break and start again?
So again, the state of mind is that we are dealing with wounds. With each session, we are increasing the amount of stem cells. So after 20 sessions or so, we have a huge amount of stem cells flying over. It's not a magic. So we need to continue and keep them up with the good oxygenation and metabolism. It means that if we are making a break, everything is going down, and then we have to build it up again. So if you decide that you want the treatment with respect to the long COVID, the minimum is 40 sessions. Those are daily sessions, 5 days per week. Each session lasts for 2 hours. So that's the minimum that is needed. Some of the people who have a complex wound might need more. Some it will be sufficient. But that's the minimum needed. So you can go to one session, travel, come back again, do another one. It doesn't happen. It's not a magic. Okay? It's a full protocol, minimum 40 sessions, once per day, 5 days per week.
Excellent. Our next question is from Jordan S. What are the risks and potential side effects of this treatment?
Every treatment have some risk, and people who are eligible to the treatment need to be evaluated, meaning different type of problem in the ears may prevent you from going in. You need to be able to equalize the pressure. If you cannot do that, you may have damage to your inner ear. There are certain lung pathology that will make you unable to be exposed to higher pressure because the lungs are feeling the pressure. This is highly important with long COVID, and here again, you need a professional who knows how to do the evaluation and characterize whether you will be suitable and will be able to hold the pressure. So that's another thing. There are some other contraindications related to, for example, to epilepsy and things like that. So to make a long story short, be evaluated by a professional. He will evaluate you, and once he will say that you are suitable, then the treatment is generally very safe.
Excellent. Next, we have Jennifer J., who's asking what percentage of the study participants were vaccinated?
At the beginning, when we started, most patients were not vaccinated. Okay? So the vaccination is not related to how you handle the wound of the post-COVID. The vaccination is related to the chance to develop post-COVID, meaning if you are vaccinated, then the time it will take for your body to eliminate the virus will be shorter. So your chance for long COVID is smaller. Okay, but once you are unfortunate and you have the post-COVID, it doesn't matter if you're vaccinated, yes or not. Now we are dealing with a wound, and this wound need to be treated.
Absolutely. Next, we have Vicky, who's asking, are there tests that can confirm COVID is the actual cause of the brain injury versus normal aging?
The answer is yes. If we have, first of all, a healthy individual that didn't have any symptoms before, and then he had the COVID, and immediately we see a brain of somebody who is supposed to be 70 with the cognitive decline and everything related to it afterwards, then it means that it's COVID. But if we want to make an absolute diagnosis that the COVID is inside, of course, we need to take the tissue out. In humans, we can do that only if, unfortunately, the patient have died from any reason, and then we can do the autopsy. And part of the picture that I demonstrate along the webinar, in some of the slides, you can see some post-mortem microscopic analysis where you can see the actual virus in the brain. But these are not a live tissue anymore.
You know, it reminds me of a question that some of my concussion and traumatic brain injury questions patients ask me. And I tell them, if you got in a car accident and that caused your traumatic brain injury and you're having symptoms, do you care the name of the driver who hit you? No. In the end, it's a wound in the brain. And, you know, whether it's long COVID, aging, stroke, you know, the key is to assess the wound and see if we can treat it.
Absolutely.
Our next question comes from Stephanie M. Are these treatments covered by insurance?
These treatments are not covered by insurance yet. Hopefully it will come a long time, but currently it's not covered yet. It's a long process for the coverage. It might be that some insurance may consider to cover it, but it will take time, probably take time, hopefully short time, but it still takes time.
And next we have another Jennifer who is asking, was this study performed in the United States or were other countries involved?
This specific study was performed in Israel. We did it in Israel. As you know, in Israel, whatever related to the COVID, we are moving fast. If you can recall, we were the first to use the vaccination in large scale. In Israel, many of the data related to the immunization came from Israel. And now we are moving very fast, and we have, for the first time, a randomized prospective control trial with the sham group that demonstrate that there is something effective for treatment of post-COVID patient. Hopefully, additional studies or intervention will be found suitable, because as much as we will have tools in our Armageddon, in our toolbox, it will be better to get even better or even faster result. But the good news is that for the first time, we have a prospective, randomized, sham-control study that demonstrates an efficacy in recovering the damaged tissue caused by the COVID.
Excellent. Next, Namanja is asking, Professor Shai, can depression be post-COVID syndrome? And is it possible that the use of hyperbaric oxygen can be used for that?
The answer is absolutely yes. This is part of the symptoms or the clinical function that are related to certain area in the frontal lobe. And we have a lot of patients who develop depression because of the COVID. It's not because of the lockdown. This is because of damage to the brain tissue. And once we see this damage and that tissue can be repaired, then the depression faint away.
Excellent. Christine is asking, how do you monitor each patient protocol, and what if I need more time or different pressures or frequencies?
Then when we are doing clinical study, then we have the limitation of the clinical study protocol. We cannot adjust based individual, but this is the limitation of a clinical study protocol. However, when we are treating a specific individual, then we can adjust the duration, the time need, and additional things that we can use in order to get the maximal results per individual. So when we are treating individual patient, as you well know, already in Florida and already in Israel and already in Dubai, the results are much better than what we have in the clinical study. And this is because we can adjust the specific protocol per the individual, what is best for this individual, and not just a generalized protocol.
Excellent. And Deborah H. asks a common question. Has COVID been found to affect blood pressure long-term?
That we don't know. This is something that we don't know yet. We do see, however, dysfunction of the autonomic system, meaning suddenly patient may have high heart rate, okay? The pulse pressure is going very high. They may have increased or decreased suddenly in the blood pressure. But usually it's not a persistent increase in the blood pressure, it's fluctuation in the autonomic system. These are the things that we know now, but it might be possible that in some of the patients it does. We are learning that now.
Absolutely. Jordy asks, will adding supplements to your diet help restore the loss of taste and smell?
Unfortunately, no. Unfortunately, no.
Yeah. Our next question is from, I believe, Melissa. If only brain fog remains, is this protocol that you're recommending, 2.0 atmospheres specifically?
It's not only brain fog. Brain fog is a huge thing. Brain fog means that the tissue is malfunctioning. It's like you're saying, I'm driving the car in 10 miles per hour max instead of driving it 100 miles per hour max. That's what it means, brain fog. Okay, so brain fog, it means that you don't see the road clearly because the glass is dirty. Okay, that's a huge thing. Okay, brain fog, it's a huge thing. It's not a specific area in the brain. It means that the whole functionality is not the way that it used to be. So if somebody have brain fog, this is a big issue and it needs the full treatment. And probably when we will do the imaging, we will see the significance of the injury.
Excellent. Well, it looks like we have time for one more question, and it comes from Dr. Yonsei. What do you think the optimal number, frequency, and duration of sessions is for long COVID recovery when using 1.3 atmospheres at concentrated O2?
1.3 doesn't work. This is not a treatment. This is not the protocol. I used the word bullshit, but this is actually bullshit. Okay, this is not hyperbaric treatment. None been proved effective. Nothing. This is not what we are doing. Don't use that. Don't play with that. If you want the treatment, get what we have studied, what we have learned in appropriate place with professional.
Absolutely. So today was a great webinar, great questions. If you guys are interested in learning more, we do offer complimentary physician consults with me or one of our other physicians, whether it's in Florida or Dubai. In our Florida clinic, you can call us directly at 352-488-2848 or go to our website, aviv-clinics.com, and you can book a free consultation. We can go over your long COVID symptoms, whether this assessment and treatment is right for you, or if you have another condition that you think we might be able to help, we're available to you. Once again, thank you, Dr. Shai Efrati, for your latest research and wisdom with all these questions. We look forward to the future ones, and the way you found this webinar is probably the same way we're going to find our future lectures and seminars. Thank you all, and be safe, everybody.
Bye.